Good morning, ladies and gentlemen. It is an honor for me to be here today, and I would like to thank the conference organizers for giving me the opportunity to present the results of the Simple HIV study, a randomized controlled clinical trial on maintenance therapy conducted in Switzerland. I have no conflict of interest to declare. The Simple HIV trial was solely funded by academic support. Treatment optimization is being increasingly explored within the sphere of lifelong antiretroviral treatment, and dual therapy has become a new paradigm in this context. Both EACTS guidelines and the FDA approved dual therapy for both naive and experienced patients based on industry-sponsored trials. In Simple HIV, switching to dolutegravir plus emtricitabine was non-inferior to continuing standard combination antiretroviral treatment, with 91% of participants having an HIV RNA less than 50 copies in both groups at week 48. Simple HIV had two primary objectives due to its factorial design. First, to assess the efficacy of dolutegravir plus FTC in HIV biologically suppressed participants switched from the standard CART. Second, to assess the cost of a simplified monitoring by applying a reduced frequency of immunological and safety measurements to once a year, as well as a patient-centered approach by offering various options for HIV care. We present here the 3 years efficacy and safety results of the Simple HIV trial. Adults biologically suppressed on standard CART for at least 24 weeks were randomized to daily DTG plus FTC versus continuing standard CART, and to a patient-centered monitoring arm versus routine-free monthly monitoring. At week 48, therapy and monitoring strategies were continued at patient and physician discretion. Main exclusion criteria included non-integrase inhibitor mutation and the previous change of therapy due to an unsatisfactory biological response. M184V mutation was admitted. Other exclusion criteria were standard. A sample size of 184 participants was required to demonstrate non-inferiority with a margin of 12%. We explored two efficacy endpoints during the post-study period. First, the proportion of participants maintaining an HIV RNA less than 100 copies throughout 144 weeks. Second, the proportion of participants having an HIV RNA less than 50 copies at week 144. Safety outcomes and change in quality of life were also assessed. We screened 873 participants and randomized 188. 94 participants were allocated in the DTG plus FTC arm. 48 of them was allocated in the patient-centered monitoring arm and 46 in the standard arm. 94 participants were allocated in the CART arm, 1/2 of them in each monitoring arm. 5 participants were lost to follow-up between week 48 and week 144 in the DTG plus FTC arm, and 8 participants in the CART arm. Here are the baseline characteristics of participants. Overall, 17% were women. Participants were mostly Caucasian. CD4 count was similar at baseline in both groups. At inclusion, CART was an association of 2 and RTI with an integrase inhibitor for 2/3 of participants. Here we present the main outcomes of the Simple HIV study. The first efficacy endpoint was defined as an HIV RNA less than 100 copies throughout 144 weeks. The second efficacy endpoint was defined as an HIV RNA less than 50 copies at week 144. Both virologically, in the intention to treat population, both virologically suppression criteria were met with criteria for non-inferiority. This slide presents differently the secondary efficacy endpoint using the FDA snapshot algorithm. At week 144, 88% of participants in the DTG plus FTC arm versus 84% of participants in the CR arm had an HIV RNA less than 50 copies. One participant in the dual therapy arm versus 4 in the CR arm had an HIV RNA above 50 copies. One participant in each arm presented an adverse event justifying treatment interruption. Overall, 6 participants were lost to follow-up, and 419 data were not available in the window period. We observed a large number of adverse events, but very few were serious. In terms of safety, we observed no difference in both arms in the change in CD4 count, renal and lipid profile from baseline to week 144. Overall, over 3 years of follow-up, female had taken 2.6 kilos and male 2.3 kilos, with no difference between the study arms. We were not able to demonstrate a change in quality of life that was already very high at baseline in this population. In conclusion, switching to DTG plus FTC was non-inferior to standard CR and maintenance therapy in a nationwide randomized trial over 3 years of follow-up. Dual therapy also remains secure in terms of safety, weight gain, and quality of life. I would like to warmly thank the Simple HIV study participants, the Swiss HIV cohort, all my colleagues and friends listed on the slide, and the Swiss National Science Foundation. Thank you.